from Microbe TV. This is Infectious Disease Puscast episode 23, recorded on March 1st, 2023. I'm Daniel Griffin, and joining me today is Sara Dong.
Hello, I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Daniel, we'll have to figure out what we're going to talk about at the kickoff of our episodes.
It says some banter ...
I feel like we can't talk about the weather because that's already taken.
Yeah, and I refuse. You may notice I never discuss the weather. The only time I pay attention to the weather is if I'm planning on sailing. Otherwise, I wander around. I'm like, oh my gosh, there's a foot of snow. Who would have seen that coming?
I thought about should I get some bad jokes to bring on, but then I'd have to prepare. We'll see. Maybe major in future episodes.
Okay. I look forward to some interesting. We can even put in the banter ahead of time just so we don't feel the pressure.
Yeah. Well, everyone, welcome to Puscast, which is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. I will be starting our viral section, and remember to listen to This Week in Virology, clinical updates for timely viral-related information. And I don't know if you know, Sara, but we are quickly approaching TWIV 1000.
Wow. 4 digits.
You'll have to come and join us. So. All right, but let me start with the article, Association Between Cytomegalovirus Infection and Tuberculosis Disease, a systematic review and meta-analysis of epidemiological studies published in JID. So first off, who thought about this? This is, a little interesting connection potentially. But before we get too excited, I will comment that these are the results of a random effect meta-analysis. This meta-analysis of risk estimates reported in individual studies showed a marked and significant correlation of CMV infection with active tuberculosis. Adjusted hazard ratio of almost 2.92. They have an adjusted odds ratio of 1.14. Okay, not as impressive there. A clear dose-response relation was inferred between the levels of CMV antibodies and the risk of tuberculosis events. And they give us an odds ratio for high levels of CMV antibodies of 4, odds ratio for medium levels of 3.58. I have to say, very interesting. I would actually, because sometimes people get sent our way, is, the person has antibodies against such and such. I'm like, well, this just represents the fact prior infection, robust immune response. Really interesting to me that there's this dose-response relationship between these serology levels for CMV antibodies and tuberculosis.
Yeah, I haven't read this one, but I'll have to go take a look at it. Always hard to know how to use our antibody tests, and I guess for CMV in particular, but
I guess we'll add this, right? We'll do the quantiferon gold and a CMV antibody level, and we'll do some Bayesian calculation of whether or not they have TB. I don't know.
Yeah.
Okay.
Well, I have the other viral paper from today, which was a brief communication in Nature Medicine entitled In-Depth Virologic and Immunologic Characterization of HIV-1 Cure After CCR5. I'm assuming you say Delta 32.
Delta 32, yeah.
Okay. You're not supposed to ever make fun of anyone if they learn something by reading it. But I meant to look it up before, but I just presumed that's how I would say Delta 32. So allogeneic hematopoietic stem cell transplantation. So this is a report on long-term HIV-1 remission in a 53-year-old man in Germany who's been monitored for 9+ years after receiving this allogeneic CCR5 Delta 32 stem cell transplant, which was performed for AML. So I pulled a couple details. He was diagnosed with HIV infection in January of 2008 and was later diagnosed with AML in January of 2011. ART was stopped about 70 months after the stem cell transplant, so that was about 2018. And so even though they found sporadic traces of HIV-1 DNA in droplet digital PCR and in situ hybridization assays in peripheral T cell subsets and tissue samples, the repeated ex vivo quantitative and in vivo outgrowth assays in humanized mice did not reveal replication competent virus. And so the low levels of immune activation and waning HIV-1 specific humoral and cellular immune response indicated a lack of ongoing antigen production. So super exciting. The I can't remember. I think I may have talked about one of the other cases, but both cases of successful HIV-1 cure that have been published. So the London patient and the Berlin patient also received a CCR5 Delta 32 allograft. And I think that there is actually a New York patient who uh, uh, has been noted in things but hasn't formally been published. So obviously not low risk or scalable, but still super exciting. And I always like to read on these, and hopefully it'll translate into something down the road that can be helpful to a wider community.
Yeah, it is interesting. I mean, I guess I'll comment on the CCR5 Delta 32, right? So this is
Mm.
a 32 base pair amino acid deletion, right? Or it's actually a deletion that results in the 32 base pair deletion. And you end up with a stop codon. And basically, these people don't have the CCR5
Mhm.
co-receptor, and so the HIV can't enter these cells. It's really sort of an ingenious idea. The idea of
Yeah.
being like that 1 in 100. I think it's 1 in 100 Caucasians that actually have a CCR5 deletion that are have this protection. But yeah, now we have the London, the Berlin, the New York, and the Dusseldorf patient, and I
Mhm.
feel like I'm missing somebody. All right, moving into bacterial. Be sure to listen to This Week in Microbiology. I'm actually in the middle of an episode right now. But let me start with the article two-step algorithm-based Clostridiides difficile. Can I just say C. diff testing as a tool for
Yeah.
antibiotic
Yeah.
stewardship published in CMI? Here, the investigators performed a retrospective analysis of positive C. diff cases over 2 years, spanning a year preceding and following their institution's transition from PCR to two-step testing. In the PCR period, results were displayed in the electronic medical record as positive. In the two-step period, positive results were either displayed as likely colonized or toxin positive. Rates of CDI specific, C. diff infection specific therapy, and adverse patient outcomes, 30-day mortality and ICU admission were compared between the groups. A total of 610 patients had positive results over the study period. Of the 354 patients in the PCR group, 93% were treated with C. diff specific therapy. This is great. Of the 142 patients in the likely colonized group, 42% were treated. Maybe I should say not so great. All 114 patients in the toxin positive group were treated. Multivariate analysis among patients who are PCR positive or likely colonized showed that testing sent in the two-step era was 20 times less likely to be associated with treatment for CDI without adversely affecting patient outcomes.
Well, this next one I was super excited about because I get this question from residents all the time. I'm doing a lot of services here, so this comes up not uncommonly. So from JPIDS, the clinical utility of MRSA nasal surveillance swabs and ruling out MRSA infections in children. So this was a retrospective cohort study of patients under the age of 18, and it yielded MRSA surveillance swabs from the nose yielded a negative predictive value of 99.4% for initial negative MRSA nasal surveillance swab. And so this was 165 hospitalized children who had some sort of suspected infection and then some correlating clinical cultures that were obtained from wherever the likely source of the infection was. And they only included patients who were actually started on empiric anti-MRSA therapy. Just to dig into this a little bit more, most of the patients were in the ICU. I think it was about 75 to 77%. 41% had indwelling hardware, and about 14% were considered immunocompromised. And I think the next question, because a lot of the studies that have looked at this have focused on one specific type of infection. So of these, 50% of the sort of suspected site clinical cultures were blood cultures, 19% are respiratory, 5% were CSF, and then there was another 20% that were sort of skin soft tissue type infections, and then 7% that were classified as bone. So only one of the 165 children developed MRSA infection within 30 days of their initial negative swab. So the authors are suggesting here that, in their opinion, the negative predictive value of an MRSA swab is less reliable. If there is over a 4-week window between swab collection and the clinical culture collection as well, because at that point, I think it tilts towards it being a little bit more likely that you could have acquired MRSA in the hospital. Um, and so I did take a look at some of the numbers for adults and then some of the studies from kids that they also, I think, reported on in the paper. So for adults, there is a meta analysis, because where we tend to use MRSA nasal surveillance swabs the most is with pneumonia. And there, the negative predictive value was 97% for subsequent culture confirmed MRSA pneumonia. There's been some retrospective studies of skin soft tissue infection and MRSA swabs with a negative predictive value of 98%. And then septic arthritis and spinal osteo is a negative predictive value of somewhere around 84%. And so for children, we've had less studies. There was a head and neck abscess comparison with MRSA swabs and found a negative predictive value of 78%. But a lot of those kids did have anti-staph therapy beforehand. And there's another study that looks at kind of a mixture of things, of skin soft tissue and so on, but had a negative predictive value of 96%. So I think this is very helpful, because sometimes we focus in on really, in adults, I think really relying on pneumonia and feeling like it probably works pretty well in other types of infections, but having a little bit less data to look at. And this is great for children, because I feel like sometimes we're sort of looking at the adult data, and it's just nice to have, even if it's a smaller study, have a little bit more information so we can peel
Yeah,
off the bank.
Yeah, no, I love that, and I think that's yeah, why are we doing this? Why do we care so much? Why do we need to know now, right? And we should, I wish like in the ER, the same way now everyone gets a COVID before they come in. I wish I had that MRSA PCR result quick enough that I could like grab the hands of the ER doc before they give everyone that first dose of vancomycin. Certainly before they give any additional doses. But it's really impressive how I mean, what makes us sick? We get infected with that which is on us, right? And so,
Mhm.
if you don't have MRSA anywhere to be found,
You come
how
in,
are you
yeah.
going to end up with this infection? And it would be great to use much less of that vancomycin.
Yeah. I just feel like the more studies we'll get, the more confident we'll feel. Because sometimes I think that negative swab comes back and people still hesitate a little bit,
Mhm.
depending, of course, on the case scenario. But hopefully, this maybe will make us feel a little bit more confident um, on the pediatric side.
Yeah, we'll do a survey of ID Puscast listeners and find out if they use less vancomycin and end up with better patient outcomes. All right. The article antimicrobial for 7 or 14 days for febrile urinary tract infection in men, a multi-center non-inferiority double-blind placebo-controlled randomized clinical trial was published in CIT. So here we're trying to figure out one or two Constantine units. These are the results of a multi-center randomized double-blind placebo-controlled non-inferiority trial that enrolled 282 men from 27 centers in France. So the first question is, can we actually extrapolate, how unique are the French men? Men were eligible, I should say French men were eligible if they had a febrile urinary tract infection and urine culture showing a single uropathogen. The French participants were treated with ofloxacin or third generation cephalosporin at day 1, then randomized at day 3 to 4 for either continued ofloxacin for 14 days, total treatment, or for 7 days, followed by placebo until day 14. The primary endpoint was treatment success, defined as a negative urine culture the absence of fever, and one subsequent antibiotic treatment between the end of treatment and 6 weeks after day 1. Secondary endpoints included recurrent UTIs within week 6 and 12 after day 1. So some sort of interesting endpoints here. So 247 participants were randomly assigned to receive antibiotic therapy for the 7, or 125 got 14 days. In the intent to treat analysis, treatment success occurred 55.7% in the 7-day group, and surprise, 77.6% in the 14-day group. Oh my gosh. Are we actually suggesting that 14 days may actually be better than 7 here? They say demonstrating inferiority. That's 7 days. Adverse events during antibiotic therapy were reported in 4 participants in the 7-day arm and 7 in the 14-day arm. They concluded that treatment with ofloxacin for 7 days was inferior to 14 days for febrile UTI in French men and should therefore not be recommended.
Hmm. I feel like I hogged all the really interesting papers this week.
What do you
Because my next one I'm super
dare you
excited
say
about.
that?
Yeah.
After that one? Okay.
Even so, I'm super. So I'm going to do my best to summarize this because I know it's hard to dig into the details. But there was a publication in New England Journal of Medicine, Treatment Strategy for Rifampin Susceptible TB, which was an adaptive, open-label, non-inferiority trial. It's also called Truncate TB, which stands for 2-month regimens using novel combinations to augment treatment effectiveness for drug-susceptible TB. Great name. Try to fix the letters so that they fit in there. So this took patients with rifampin-susceptible pulmonary TB treated with standard therapy, meaning your 4 drugs, rifampin, isoniazid, pyrazinamide, ethambutol for your 8 weeks, followed by RIF and INH for 16 weeks. So a total 6-month regimen, and compared it to a strategy of initial 8 weeks or 2-month regimen with extended treatment if they had persistent clinical disease, monitoring after treatment, and then retreatment if they have relapse. So basically, starting with a 2-month regimen with some caveats and close monitoring afterwards to decide what else to do with their drugs. And so the regimens were high-dose rifampin and linezolid, high-dose rif and clofazimine, rifapentine and linezolid, bedaquiline with linezolid, and all of those combos that I told you with INH, pyrazinamide, and ethambutol. And so if patients had persistent disease at week 8, or there were issues with missed doses, the 5 drugs, so they had their 2 combos and then your isoniazid, pyrazinamide, ethambutol, they would extend their treatment to 12 weeks. And if they had persistent disease at week 12, they were switched to standard treatment course to complete 24 weeks of treatment. And so the trial design's a little bit complex. So basically there were 5 groups to start. And then they had some high-risk patients that were initially excluded that they later included. But patients were randomly assigned to a control group. And patients in the 4 other groups got one of the intensified regimens I mentioned. And the plan was to drop 2 of the groups. But none of them met standards. So basically the enrollment was stopped in 2 groups on the basis of other logistic criteria, so pill burden and regulatory concerns, to preserve statistical power. So really the 2 remaining groups were high-dose rifampin and linezolid, or bedaquiline and linezolid, one of those 2 with INH, pyrazinamide, ethambutol. So I know that's a lot of words all at once, but hopefully that's as succinct as I could get it. I'm sorry,
Letters
guys.
and consonants and vowels.
Yeah. So the primary outcome was composite of death, ongoing treatment, active disease at week 96 with a non-inferiority margin of 12 percentage points. They had 675 participants at 18 sites in 5 countries, and really almost all of them completed the trial and follow-up period. They found that 3.9% or 7 patients had the primary outcome event in the control group, compared to 11.4% in the RIF linezolid group and 5.8% in the bedaquiline linezolid group. So The strategy of the 8-week bedaquiline linezolid regimen was determined to be non-inferior to standard treatment. That's sort of the take-home point here. 86% of those in the bedaquiline group did just 8 weeks of treatment. So the overall mean total length of treatment in that group was 84 days rather than 180 in the standard treatment group. So shorter total duration, no obvious safety issues, which I think is probably part of the concern with bedaquiline and linezolid. We still need to understand a little bit more. There was some acquired drug resistance in the bedaquiline linezolid group, but very small numbers. This is still a tough regimen that would certainly have challenges with adherence and resources, I'd say particularly outside of a clinical trial, but this is super exciting, right? It's a 2-month regimen that could potentially work for patients with pulmonary rifampin susceptible TB. Oh, okay. That was as short
Okay.
as I could get it.
Yeah, no, I think this is great, actually. I mean, I'm sort of going through this. It's nice that the clofazimine is sort of removed from the mix because those of us that have had to use that medicine, there's issues. And so it's nice not to have that in there. I won't even go into the issues. And the idea that you can do 8 weeks, I'm thinking about someone gets one of those, the gene expert where you know right away that it's rifampin susceptible, it's TB. You get them on this 85-day regimen, 8 weeks. That's tremendous compared to 180. I do worry about the having someone on linezolid for 90 days. He's really getting into the marrow suppression and other issues there.
Yeah.
No, this is great stuff.
Yeah. So I wasn't at Croy. I think they must have presented it at Croy because I feel like I saw a lot of people who were quite excited about it and maybe heard some updates. But you can definitely check out the paper now at New England Journal.
Yeah, I'm trying to figure out where will this get introduced? Are people going to start going down this road? It'd be interesting to see if this actually gets
How to use
translated
it.
into practice.
Yeah.
All right. Well, I've got a couple articles that I found interesting. So, current pyuria cutoffs promote inappropriate UTI diagnosis in older women, published in CID. So here they were looking at a pyuria cutoff to help distinguish asymptomatic bacteria from UTIs. So they point out that over 90% of asymptomatic bacteria patients have pyuria. And a lot of times folks jump in there with what they refer to, and I will agree with, unnecessary treatment. So here they quantified pyuria to determine the diagnostic accuracy for UTI and to derive pyuria thresholds for UTIs in older women. And I think this is something that, sort of we often tackle with. So here they included 164 participants. UTI patients had higher median urinary leukocytes compared to control patients. And so we're talking about 900 versus 26 leukocytes per microliter. Area under the curve was 0.93. Now they introduced a cutoff of 264 leukocytes, saying sensitivity and specificity of microscopy was 88%. It is interesting. They say that a commonly used cutoff of 10 leukocytes per microliter has a poor specificity, about 36%. I think a lot of us actually use 50, this greater or less than 50 as a slightly better cutoff. This continues to be a challenge, trying to limit the amount of antibiotics that are unnecessarily given for true asymptomatic bacteria versus, we'll say a patient where it's very difficult to assess those symptoms and determine the appropriateness. Now, this one I found really interesting, and maybe you can weigh in a little bit on this, Sarah, if you find this as interesting as I did. The article "Efficacy of Doxycycline for Mild to Moderate Community-Acquired Pneumonia in Adults: A Systematic Review and Meta-Analysis of Randomized Controlled Trials," published in CID. And it did get me to wondering if perhaps I don't use enough doxycycline. So they start off by reminding all of us that doxycycline has been recommended as a treatment option for non-severe community-acquired pneumonia in adults. Here, they sought to review the evidence for the efficacy of doxycycline in adult patients with mild to moderate community-acquired pneumonia. Count me as reminded. And yes, I am curious. What is the evidence for this recommendation? The authors performed a systematic review and meta-analysis of RCTs, randomized controlled trials of doxycycline versus comparator to assess the clinical efficacy. The primary outcome was clinical cure rate. Now, in this review and meta-analysis, they included 6 randomized controlled trials with 834 clinically evaluable patients. The trials were performed between 1984 and 2004. Comparators were 3 macrolides: roxythromycin, spiramycin, and erythromycin. Wow, not using enough of these either, if I think about it. And 3 fluoroquinolones: ofloxacin, fluoroxacin, and levofloxacin. Trying to give up those as much as I can for Lent. 4 trials had an overall high risk of bias. Not great when you only have 6 trials and 4 have high risk of bias. They reported that the clinical cure rate was similar between the doxycycline and comparator groups, reporting at 87% versus 83%. Adverse event rates were comparable between the doxycycline and comparator groups. Some nice figures with forest plots, but still stuck on only 2 randomized control trials without high risk of bias. The other issue is that in the US, we have overall, 30% of pneumococcal isolates resistant to the macrolides. So they seem like a poor choice unless something else is on board to cover the pneumococcus. Any thoughts? Is this something you're seeing much doxycycline in your, shall we say, neck of the woods?
I don't know. I don't think so. But you're right. I don't know. I feel like people don't tend to suggest the doxycycline, despite it being people's favorite antibiotic for most other reasons. Yeah, yeah, I have to admit, I don't know that I've used it a lot for CAP.
Yeah, I was also trying to get some good, even local antibiogram information on, if you're worried about, strep pneumo as your most common pathogen and you're thinking of
Yeah.
doxycycline, is it going to help me? What does my antibiogram tell me about my local resistance rates? And I have to say, I looked through a bunch of different hospital antibiograms, and the doxycycline susceptibility resistance information was lacking.
Interesting. Well, I'll move us into our fungal section. This first one is relatively short. I pulled this paper from OFID, Hospitalizations for Unspecified Mycoses in a Large Administrative Data Set and Implications for Fungal Disease Burden Estimates, US 2019 to 2021. So fungal diseases are often coded as B49 or quote unspecified mycoses in data sets that are used to estimate disease burden. So in this paper, they took a look at a large administrative database and found that 51% of the unspecified mycoses hospitalizations during this window of 2019 to 2021 had positive fungal lab testing. It was typically Candida, so it was about 79%. And 92% of the patients received some sort of systemic antifungal medication, suggesting that they were being treated for a true systemic fungal infection, or at least assumed fungal infection. So it's not clear why these cases were not ultimately assigned the code for candidiasis or something similar to that. So just highlighted the need that perhaps if we adjust how the coding is placed in, that maybe we would capture these a little bit better if you happen to be looking at data from these types of sort of administrative sets, which is important if that's the data that's going to inform how you make public health decisions. So interesting.
Yeah. Yeah. No, the poor coding is a challenge. When I was chief of medicine many years ago out in Colorado, and we would have these individuals that go around and they would put little notes in the chart, doctor, wouldn't it be nice if you, actually coded this renal failure appropriately? And, they would give you little advice.
Yeah.
And then periodically, if you did a good job, you might get some movie tickets. Pre-COVID, right? No one wants those now. Oh my gosh, I'm going to a movie and get COVID.
Oh, I don't
But
think
no,
I've
I think
ever gotten a movie ticket for doing a good clinical documentation query, but now the bar has
wouldn't it
been
be?
set very
Yeah.
high.
Yeah, and it was like gambling, right? Because you never knew, boy, if I do a really good job, maybe this will be the time that I get those tickets. Yeah, so let's do a better job. Right. The article Invasive Mold Infections Following Hurricane Harvey, Houston, Texas, published in OFID. This was interesting. They found that invasive mold infection incidents at 1 year before and after Hurricane Harvey at 4 hospitals in Houston, Texas, was significantly higher post hurricane. And this was went up to 3.69 compared to pre-hurricane at 2.50 cases per 10,000 healthcare encounters, with Aspergillus being the most common species cultured. And over 1/4 of the patients, the invasive mold infected patients, lacked classical invasive mold infection risk factors, such as hematological malignancies and transplantations. Um, Overall, 45% of the invasive mold infection patients received ICU care, and in hospital all cause mortality was 24%.
Interesting. And then I will round this out for fungal. I have the article Cryptococcal Meningitis and Clinical Outcomes in Persons with HIV, a Global View, which was recently published in CID. So these are the results of a retrospective cohort study that investigated cryptococcal meningitis incidents and all-cause mortality in people with HIV. And I actually wasn't sure how they say this database, maybe IDEA, but it's international epidemiology databases to evaluate AIDS. So it's sort of spells out kind of like IDEA. But this is a research consortium established by NIA that collects data from various regions of the world. And the cohort is from 1996 to 2017. And so they found a couple points that I'll emphasize. So they reported that among the 518,000 people with HIV, there were 3,857 diagnosed cases of cryptococcal meningitis. So that's an estimated incidence of 1.54 per thousand persons years, which is decreasing over time, but somewhat variably depending on what region they were looking at. This paper demonstrated the high mortality. So the mortality over a median of 2.6 years of post-cryptococcal meningitis diagnosis follow-up was 31.6%, but there were 29% that were lost to follow-up, and some of that might be because those patients died. The prior reported rates of mortality, it seems like, have been somewhere in this like 30 to 40% range. And they did find that higher mortality was associated with older age, lower CD4 count, and an earlier year of cryptococcal meningitis diagnosis. The other sort of 2 points to make is there was a substantial portion of the meningitis cases that were identified after ART was started. So 64% were diagnosed after starting HIV therapy, but it was a median of about 8 months from the time they started ART to their diagnosis. So these were not, at least it doesn't seem like, patients who were sort of started on therapy and kind of unmasked their cryptococcal meningitis. And then many sites lacked access to the recommended treatment option. So of 89 sites, only 34% reported access to amphotericin B and 12% had access to flucytosine. So I thought that was a really interesting paper. And you would think that there's been more change, I think, than there actually has been, unfortunately.
Yeah. Little troubling. And that 31.6% mortality and a 29% loss to follow-up, so probably even higher. So not great. All right. Parasitic. Be sure to listen to This Week in Parasitism, our most recent episode. We just had my friend Kai Schaefer joining us, Trop Medics from Cologne, Germany. I was impressed. Everyone seemed to speak German on the show. I deny being able to understand any German. So, but the article "Rapid Range Shifts in African Anopheles Mosquitoes Over the Last Century" was published as a research article in Biology Letters. And here the investigators used, as they say, one of the most comprehensive databases ever compiled by medical entomologists to track the observed range limits of African malaria mosquito vectors from 1898 to 2016. And then using a simple regression approach, they estimated that these species ranged gained an average of 6.5 meters of elevation per year, and the southern limits of their range moved, are you ready for this? Polewards at 4.7 kilometers per year. These shifts are consistent with the local velocity of recent climate change, which is a thing, and might help explain the incursion of malaria transmission into new areas over the past few decades. If that wasn't frightening enough, is this the title of a new film? Neuroangiostrongylosis rat lungworm invades Europe. Actually, it's a letter to the editor that was published in the American Journal of Tropical Medicine and Hygiene. And here they report that Angiostrongylosis cantonensis has been reported in the Canary Islands and Majorca. The parasite has now been detected in the mainland, in the city of Valencia on the Spanish mainland.
Mm.
And the advice from the authors: educate the general public on how to avoid eating slugs. Okay,
There you go.
don't eat those slugs.
And I don't know, to move us into the miscellaneous section and sort of continue this theme of scary things. I don't think we've covered an amoeba in Puscast yet. Maybe we have. Maybe you did, Daniel. But there was an OFID ID teaching case, Balamuthia mandrillaris encephalitis, presenting as a symptomatic focal hypodensity in an immunocompromised patient. So this case reported a 61-year-old female, almost 2 years post heart transplant, who was hospitalized for new onset headache and had a brain MRI that showed a hyperintense signal involving the left occipital lobe with leptomeningeal enhancement and mild vasogenic edema. She later developed imbalance, visual disturbances, alexia without agraphia, and right hemianopsia. And a subsequent repeat MRI showed enlargement of this occipital mass and edema. When they did a needle biopsy, it just showed non-diagnostic necrosis. And unfortunately, the patient deteriorated despite treatment with dexamethasone, Vanc, imipenem, ganciclovir, which was due to a CMV CSF PCR, which was positive, and AMPHO due to a positive beta-D-glucan. And ultimately, the postmortem broad-range PCR sequencing of brain tissue was positive for rare amoeba balamuthia. So pretty scary. One of their learning points was to consider next-gen sequencing as a diagnostic tool early when the etiologic diagnosis is elusive. Would sending something like a Curious test have changed the outcome in this patient? I don't know, because ultimately this Balamuthia encephalitis is a pretty high mortality, but just something to think about. Amoebas are scary.
Yes, and I have to say, having seen some cases of Balamuthia mandrillaris, very, very scary when it comes to the amoebas. All right, the article, and I'm closing us out. The low rates of antibiotics. Hang in there, you're almost there. The low rates of antibiotics prescribed during telehealth primary care visits persisted during the coronavirus disease 2019 COVID-19 pandemic, published in Infection Control and Hospital Epidemiology. This is my plug for keep those telehealth visits going. They're a great way of continuing to provide access, and we seem much more comfortable in that setting saying, no, you do not need that unnecessary antibiotic. So here the investigators used administrative data from the VA administration to conduct a retrospective cohort study of patients seen in a primary care clinic at a VA medical center in the 2 years before the COVID-19 pandemic, and then after March 1st, 2020, so during the COVID-19 pandemic. And they found that there was a reduction. There was actually a decrease in the associated antibiotic prescribing that was before and also continued in these telehealth visits during the COVID-19 pandemic.
Nice. Well, congrats, friends. You've made it to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, at microbe.tv/Puscast, and on your favorite podcast catcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders, parasiteswithoutborders.com, and click on the donate button.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I am Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.